The draft guidelines on the management of patients with abdominal aortic aneurysms have been in the public domain now for over a year. They followed the normal NICE process of public consultation, but I think the amount of feedback NICE received was unprecedented. It's a very long guideline, but within it there are some highly controversial ones, and in particular the guideline around elective aneurysm repair. Now this states that we should not offer EVAR to any patients. The amount of feedback NICE have received has been unprecedented, and in the light of that they've been through quite an unusual process. Firstly, they delayed the guideline. Secondly, they put the draft guidelines through a process of internal review. Our understanding is that that was completed and further consultation took place with the guidelines committee. Subsequent to that, there's been further discussion between the various stakeholders, which has culminated in the presentation of the draft guideline to the NICE board. So the current situation is it sits with the NICE board. The next step we're unclear about, but what we are clear is NICE are listening to us and our concerns, and we remain in dialogue with them to try and find a workable solution to the draft guidelines. I think the major challenge relates to the draft guideline that states that EVAR should not be offered to all patients in an elective setting. Now, vascular practice in the UK has changed dramatically the last 10 years, such that now over 2/3 of patients are treated using endovascular technologies. So a shift back to open surgery for all patients would have huge implications across service provision and also potentially on the outcomes for individual patients. Fundamental to it for us has been the element of patient choice. So patient choice is at the heart of everything that the NHS does, and particularly for aneurysms, that decision-making process based on careful evidence that is assessed by the clinician and portrayed to the individual patient is so important in determining what is the best methodology for their individual treatment. So I think the way the guideline or the draft guideline was written such that that choice was removed was quite a problem for us and for other stakeholders. But then taking that forward, if we think about the implications for the service, going back to open surgery would mean a much greater need for resource in terms of intensive care, bed days, patients would stay much longer, and also for theatre use. So the procedures are generally longer, need a different environment, and so all of that combined, I think we would need a significant resource boost to be able to actually provide the service. Then there are issues around training and provision of emergency services. So we have a workforce now that is largely de-skilled in open surgery, especially complex open aortic surgery. And so there would be big implications for training existing consultants, but also for those trainees coming through the system who really want to be involved in modern endovascular technologies. So I think we might find that we lose quite a lot of our training resource. And finally, the emergency setting. We have a draft guideline that states no use of EVAR in an elective situation, but to use it preferentially in emergencies. And that creates huge challenges. So providing a service that we don't do during normal daytime hours, but are expected to provide out of hours, I think is unworkable. What's very important is NICE are clearly listening to concerns, not only from clinicians and surgeons, but also from all stakeholders involved in the provision of vascular services. So there clearly needs to be some form of change in the wording for it to be an acceptable guideline in the public domain. I think there needs to be compromise from both sides though. I think most clinicians with experience in aortic disease accept that perhaps we've taken things too far with endovascular technologies. So actually perhaps a reappraisal of where endovascular technologies lie in the aortic service is important for all of those that provide that service. So I do think we need to consider where perhaps those use of technologies are inappropriate, the elderly, the frail, perhaps patients with smaller aneurysms, but also in the younger patients with a very long life expectancy. Perhaps open surgery is the better methodology for them. So I think we need to see compromise on both sides and a much more balanced view. The do not offer EVAR situation, I think, is unacceptable to all, but we need a much more balanced view. So do not offer to some, or perhaps preferentially offer open surgery to some, and similarly do not offer EVAR in some of those who we really don't think they're going to get benefit. Now, alongside that, I do think we need a much better research base for all of this. So actually determining who's going to benefit most or perhaps least from endovascular technologies, we're not necessarily that good at the moment. So we need much better work on who's going to benefit most from which approach, and better selection criteria so that we can guide patients to what we think is the best option for them.